Good morning, everyone, and welcome to one more lecture of surgical infections. This one is the continuation of the previous lecture. In the previous lecture, we have discussed about the basics and also the surgical site infections, SSIs. In this one, we are going to talk about the other surgical infections, which I told you the list in the previous lecture. So we are going to start discussing cellulitis, abscess, and necrotizing, plus some other infections. So basically, the infections of the skin and soft tissues, when we classify them according to the um, what you can say whether the surgical intervention is required or not. For example, uh, superficial skin and skin structure infections are called as cellulitis, and then there is erysipelas, and then there is lymphangitis. And if I will talk about cellulitis, for example, like surgical intervention is not needed most of the time, or you can say almost all of the time, and antibiotics are enough to deal with these infections. So, whereas you can say uh, furuncles or boils uh, may require a surgical incision and drainage, plus antibiotics, of course. But then there are surgical infections, what you can say, some of the infections, or you can say the aggressive soft tissue infections, which are rare and difficult to diagnose. They do require immediate surgical intervention plus antibiotics, because like if we are not going to provide that, the mortality rate is very, very, very high. You can say 80% to 100% sometime. For example, gas gangrene, okay. For example, necrotizing fasciitis, okay. So that's how I classify. So first of all, we will talk about the soft tissue infections, and then the first one, I'm going to talk about cellulitis. You can see like the same thing which I was talking in the previous lecture: calor, rubor, dolor, and tumor. Calor means heat, and rubor means redness, and dolor means pain, and tumor means swelling. So we can see like all of these in this photographs, right? So what is cellulitis basically? Cellulitis is the uh, diffuse infection with severe inflammation of the dermal and subcutaneous layer of the skin. Uh, now, like cellulitis, what you can say uh, is a very it's an infection of the superficial layer of the skin, and the presentation is exactly like this. You can see like the redness, you will find the tenderness, you will find the swelling in that region. Maybe in some of you, you have a question in your mind, why they put this line. This is not just to take this photograph, but like any patient who is have cellulitis, what they do is like uh, they mark it in the hospitals like this, so that they must know like either this infection is localized in this region, or either it's healing up, or either it's spreading more. Okay, so like whenever a patient of cellulitis you will found in a real surgical ward, you are going to find the same thing, a marking like this. Okay, so as I discussed previously, like just now, I was telling you that infections like cellulitis or erysipelas, these infections, they don't need much surgical intervention. So non-surgical treatment is enough for them. So how we diagnose them? By examination, by taking history, and in the examination you are going to find the same thing, the redness, you're going to find the inflammation, you're going to find the swelling, you're going to find the tenderness, or you may find a loss of function. For example, like of course, like a person who have a cellulitis like this or like this, what will happen is the patient, of course, they cannot move their hands or their feet, their ankle, or whatever like the region is involved, like a normal person, but rather you can say the range of motion will be either reduced or either very little. Okay, so these things can be there. So cellulitis, it's a non-suppurative invasive infection of the tissue, and there is a poor localization in addition to the other signs of inflammation, which is pyrexia and all the stuff. So, what are the organisms which are involved? See, Streptococcus and Staphylococcus. So, these are the normal flora of the skin. Okay, and uh, this is the most common organisms, which are involved in this one. Okay, one thing about cellulitis is what? Okay, like it can lead to tissue destruction. It can lead to ulceration, for example, but very less commonly. Okay, so in cellulitis, maybe you will find a history of trauma, a history of surgical procedure, or anything like this. Of course, due to what the common flora of the skin have invaded the deeper structures, and it lead to having this surgical infection. So, what is the treatment? Treatment is simply by antibiotics, and antibiotics like uh, if you will see Streptococcus or Staphylococcus, which are the gram-positive bacteria or the gram-positive cocci. Uh, so we are going to use the antibiotics which are effective against that. So penicillins, flucloxacillin, and all these drugs, they have a very good results for this condition, and these drugs can be given to the patient, and of course, like they can be managed, of course, like with some painkillers or anti-inflammatory drugs if needed. So you can see over here like the difference between cellulitis and lymphangitis, sorry, the description of cellulitis and lymphangitis. Uh, Lymphangitis, it's almost similar to cellulitis, and what you will find is like painful red streaks along the line of lymphatics, of course. Okay, so they are non-suppurative, they are poorly localized, they are commonly caused by streptococci, staphylococci, or clostridia, and systemic inflammatory response syndrome is common. Blood cultures are often negative. Okay, so remember the systemic inflammatory response syndrome. We have discussed this thing. So of course, the patient will present with uh, pyrexia, um, tachycardia, tachypnea, and also the white blood cells count can be less than 4,000 or more than 10,000, right? So these things can be present, can be present. So this is like about what you can say, the lymphangitis or cellulitis, and most of the times, nothing is needed. Then there is abscess. Now, abscess is basically a collection of pus in a closed cavity. And if you know, like, what is pus, basically, pus is um, the dead white blood cells, uh, of course, like whenever there is any infection at any part of the body, what happens is like the infection fighting cells, which are WBCs, they are migrated towards to that area, and when they are migrated to that area, they are the one which release the cytokines and oxygen free radicals and all these things. So of course in process of that, they dry and they collect over there, and that is basically what pus is composed of. So now, the thing is, whenever you are going to find abscess anywhere in the body, for example, or superficially anywhere in the body, of course abscess can be deep, abscess can be superficial. You are going to find an area of inflammatory response around that. Okay, and we are going to find the same things which I talk about, that is the color, the redness, the warmth, or you can say the increased temperature, the tenderness. Okay, so that's the thing, that's the thing you are going to find in that one. So what is antibioma may be formed. So of course, like, whenever there's oma, it means like tumor. So uh, that can be there. So the abscess is usually surrounded by an area, we call it as pyogenic membrane, that is composed of fibrinous exudate and edema. And later on, you can find granulation tissue around that, which is formed by macrophages and fibroblasts. So, uh, uh, of course, like whenever, like one rule, remember, guys, whenever there is any abscess in the body, we must drain that, because if we don't drain the abscess and chronically it is present, it can change into the chronic abscess. Uh, uh, so what, like chronic abscess, like for example, if someone have abscess and you are giving them antibiotics and you are not going to drain that, what will happen, of course, the antibiotics are going to kill all the bacteria over there. So you can say like, there will be a collection of a sterilized fluid which is now organized uh, by, you can say, collagen deposition, so that is what we call it as antibioma. Okay, so antibioma may form if the abscess is not drained. So again, like how we diagnose abscess, guys, again, uh, like we go for examination, we found a fluctuant, movable, and compressible mass in that area. Of course, in the start, it is painful. Sometimes, the abscess, uh, uh, it start draining outside from the surface of the skin. So that thing. So as a result of surgeries, whenever abscesses are formed as a result of surgery, it takes around 7 to 10 days, for them to form. And most of the abscesses which are formed as a result of surgery, they are formed at the site of the surgery. So what happened is, like, the patients, they present after 7 to 10 days with maybe the signs of fever and, like, what you can say, systemic inflammatory response syndrome. And then what we have to do, we have to drain that. Okay, so drainage followed by antibiotics is very, very, very important. So you can see over here, abscesses need drainage with curettage. Modern imaging techniques may allow guided aspiration. Antibiotics are indicated if the abscess is not localized. For example, evidence of cellulitis is there, and healing by secondary intention is encouraged. So of course, like, depending on where is the abscess, it could be superficial, it could be deep. For example, someone who have a deep cavity abscess, then of course you have to localize that. And nowadays, of course, we have some imaging techniques like CT scan, MRIs, and all these things, so we can localize that. And by the help of, nowadays, by the help of minimally invasive, or you can say less invasive techniques, like laparoscopic ways, we can drain that abscess. Okay, but the important thing is, like, the drainage is very, very, very important. So someone in which, like, the abscess is not drained and it is left chronically over there, of course it can change into persistent chronic abscess, which can form a sinus or fistula formation. So, and later, like if a chronic abscess can be later calcified as well. So, this is like about um the abscesses, okay, and the different type of abscesses. Okay. Uh, Other than that, abscesses, uh, there are some infection or specific wound infection. So in specific wound infection, you can see like three names over here. One is gas gangrene, one is tetani or Clostridium tetani, and one is necrotizing fasciitis. So we are going to discuss them one by one, and the first one is gas gangrene. Um, so gas gangrene is caused by Clostridium perfringens. Okay, we know if you know if you're good in microbiology and you know like what is aerobes and what are anaerobes, what is gram positive, what is gram negative, and then there is bacilli, then there is or bacilli is the old name nowadays they call it as rods, or what are the atypical bacteria, right? So this one is a gram positive anaerobic, and if you will see like spore forming rod. Okay, now clostridiums, uh, right now we are discussing Clostridium perfringens, but uh, as a whole, Clostridia or Clostridium tetani, even they are widespread in nature, and they are present in soil and feces, and that's why if uh, any person who had a history of trauma or after road traffic accidents nowadays, you know, one of the thing we do is like we provide them with tetanus vaccine, right? Or immunoglobulins, of course, just because uh, we don't want them to develop tetanus, because when someone have tetanus, the mortality is very high. Now, the thing here is that um, uh, what happens like someone whenever they have any okay, nowadays the chances of gas gangrene as a result of surgeries is very 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 rare, but for example, in traumatic surgeries, someone who had a road traffic accident, for example, they may develop these kind of things, uh, or for example the patient is immunocompromised. Okay, so what happened, uh, any person who have any wound which have a necrotic means dead tissue or foreign material, what happens like uh, they are the perfect site for this clostridia to grow, because they need anaerobic uh, uh, environment to grow. So of course, wherever there is enough blood supply, so of course like there is supply of oxygen, but any necrotic tissue or a foreign material is present, they provide a good anaerobic condition, or you can say environment where there is no oxygen. So what happens, that these are the areas where these can grow. So what happens, like any patient who have uh, and one of the things is military injuries as well, like as a, in warfare, as a result of what you can say gunshots or uh, bomb blast, injuries like this. What happens is uh, like they can get this gas gangrene. So what happens like whenever they have gas gangrene, they have severe local wound pain and crepitus. So that's why it is called as gas gangrene, because there is gas in the tissues. So when there's a gas in the tissue, which can be seen on the plain radiograph, you can see over here, and when we palpate that, basically we hear, or there is a crepitus over there. So that's why this is called as gas gangrene. So remember that there is pain, there is crepitus, and the wound basically produces uh, a thin, brown, sweet-smelling exudate. Okay. Uh, like one of the thing, of course, we can send that exudate to the lab, and they can check like what's there, so they can found this bacteria. But the diagnosis can be done clinically as well, based on the history, based on the examination findings. So of course, this is the important thing. Plus, they will present with the signs of, or the with systemic inflammatory response syndrome. So now, what can be done for these patients? Antibiotic prophylaxis can be considered in these patients, uh, especially when we are performing amputations, or which are performed for peripheral vascular disease. Like peripheral vascular disease, these are the conditions where the blood supply is not getting to the uh, peripheral areas, like the foot in diabetic patient and things like this, or the wounds with open necrotic ulceration. So we can give them this one. We can give them antibiotic prophylaxis, or uh, what you can say. When someone is have already developed gas gangrene, then what is the treatment which can be given? We can give them, again, remember, it's a gram positive cocci, rod, and penicillins are well affected, like act against them. So large doses of intravenous penicillin can be given to them. One of the things which is I like to mention over here, before, one of the treatment which was given to these patients was hyperbaric oxygen, like you can say providing extra oxygen to these patients like under pressure. It was believed like it's an anaerobic organism, so that is one of the treatment for this thing. But now, hyperbaric oxygen is a controversial. So you can say some of the parts of the world, some of the hospitals or some of the centers, they still give them, but some of the areas, because many of the researchers, they show like there is not much, you can say, effect of hyperbaric oxygen. So hyperbaric oxygen can be given to these patients. So this is about gas gangrene. And then the next surgical infection which we are going to cover is Clostridium tetani, which is also called as tetanus. So the good thing is, we already what you can say, cover about, or talk about Clostridia. So I don't think so. Like we are going to talk about, like we have to explain the same thing, uh, same story again. But again, it's Clostridia. It's anaerobic. It's a spore for bearing or spore forming bacteria. And now, uh, it have the same story what we have covered about gangrene. So again, I gave you the example of road traffic accidents. When the patients, they come because of road traffic accidents, they can be offered tetanus tetanus vaccine. So now, uh, Clostridium tetani can result into tetanus. Tetanus is the name of the condition. Remember this thing. So again, like Clostridium tetani, it's widespread in nature. Okay, it is present in the soil, and uh, many of the times, for example, someone who had a road traffic accident, or someone who had um, spray put, or you can say step on a rusty nail, a nail, a old nail which have a lot of rust on that, by these puncture wounds, this Clostridium tetani, it can enter inside the body. So what happens, like when anyone have this thing, so what it do, it release exotoxin, which is called as tetanospasmin. So this is the name of the toxin which this tetanus release. So what happens, like this exotoxin, uh, which is tetanospasmin, it basically ascend to the uh, 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 through the nerves, you can say, and it affect the motor neurons of the anterior horn of the spinal cord. So due to that, what happens is, like, um, there is spasm in the muscles. Okay, so anyone uh, who have this Clostridium tetani in their body as a result of trauma, and they are not vaccinated against tetanus, uh, what happens is, uh, once the tetanus condition develop, the mortality is high. There is a short prodromal period which has a poor prognosis, and it's very difficult to diagnose in this one. So what happens, like anyone who will start developing this condition, they started having spasms of the muscles, and due to that spasms, they can go into a particular spastic condition, or you can say a shape of the body. You can say, the person, if you will write this term on Google, you will found that, it's an inverted C type of position, because of the back, the muscles of the back, they go into spasm. So the person, they can have this condition. Or sometimes, the muscles of mastication, they can go into spasm, and we call this condition as locked jaw, like their jaw is locked because the muscles are in spasm. So they have this thing, and they have, like, generalized, you can say, uh, muscle spasms, and that can lead to respiratory arrest and death even. So you will, like, okay, how we diagnose that thing? Of course, like in case of trauma, anyone who is brought to the hospital, you can found that, uh, you can appreciate, or you can see the entry wound. Okay, and they may have, what you can say, pain at the site of the injury or the site of the entry of the wound. So very easy way to prevent this condition is prophylaxis. So of course, like nowadays, all the kids who are born, they are vaccinated. In developed world, even the adults, they get vaccination for tetanus, every 10 years. So there is a full table, by the way, when you will study tetanus, in infectious conditions, you are going to see that table. What I'm talking about is, like, when to provide tetanus vaccination, when to provide tetanus immunoglobulins in what patients, again, like, that's a different discussion. uh, so now, uh, prophylaxis with tetanus toxoid can be given, and we can also do debridement. What is debridement? Like, it is, you can say, removing that area. Okay, so minor debridement of the wound can be done. And antibiotics, again, it's a gram positive, so benzyl penicillin can be used in these patients. But of course, like, if the patient have uh, like uh, like developed a severe condition, then, maybe we need some muscle relaxants, and if there is respiratory arrest, the person may need ventilation. Okay, uh, so this thing can be done. And here, like, as I told you, the use of antitoxin using human immunoglobulins is also used. Okay, so but the good thing nowadays is, what, as I told you, especially in developed world and in developing countries, nowadays tetanus vaccination is quite common. And these vaccine is given in 3 separate doses, and it provide protection for 5-year period. Okay, so like, after 10 years, like, they give, what you can say, tetanus vaccination to the general population. So, but anyone who is not vaccinated against tetanus, of course, we must give them immunoglobulins as well as TT, tetanus toxoid, both to these patients. Okay. Other than that, there is necrotizing fasciitis. Okay, this one have many names, like it is also called as subdermal gangrene. It is also called as synergistic spreading gangrene. Okay. Now, one of the thing, guys, because we were studying uh, like gas gangrene and tetanus, uh, remember uh, this one is not caused by Clostridia. Rather, uh, necrotizing fasciitis is caused by multiple, or you can say mixed organisms, right? So it could be coliforms, staphylococci, bacteroides, anaerobic streptococci, and peptostreptococci. Okay, uh, so necrotizing fasciitis is caused by multiple organisms which together act in synergy. So what is synergy? Okay, see, uh, 2 plus 2 is equal to 4. So that is what you can say the normal effect. So for example, if someone is infected with streptococci and staphylococcus, they are causing like streptococci is causing 2, like I'm just giving the numbers to the damage they have caused. So if streptococci is causing damage of 2 quality and staphylococcus is also causing damage of 2 quality, so the addition of them is making 4. But if streptococci is making 2 damage alone and staphylococcus is making 2 damage alone, if both of them are causing what you can say a damage to the amount of 6 or 8, so the effect is more uh, when we add them. So we call it as synergy. So simply, these all bacteria, they are causing much bigger damage, or they are acting in synergy, they are causing much more damage. We call it as necrotizing fasciitis. Okay, so when this necrotizing fasciitis occurs to the abdominal wall, we call it as Melanese hospital gangrene. But whenever this one is causing scrotal infection, it is called as Fournier's gangrene. So I did not write Melanese gangrene over here because that is not so important, but I wrote this scrotal infection as called as Fournier's gangrene because maybe you can encounter this thing somewhere in MCQs in any XYZ exam. Okay, so most of the patients who get this kind of infection, they are immunocompromised or they have chronic conditions like diabetes mellitus. Okay, and what you can say, the thing is, what is important about this thing is what uh, they present with uh, severe pain and inflammation. There could be crepitus, and if it is not treated in time, it can result into widespread gangrene. Okay, as well. So now the important thing to know here is how we treat that. We treat them with broad spectrum antibiotic with aggressive circulatory support, and excision of all the necrotic tissue is important. Okay, so this is how necrotizing fasciitis present. Okay, uh, next to that is furuncle. Now what is furuncle? um, Guys, furuncle is basically abscess in a sweat gland or a hair follicle. I'm sure when I will show you, you would understand what I'm talking about. See, it's a very, very, very common infection. So this is called as furuncle. Okay, see, okay, this one is okay. How we treat that, of course, like there is a small abscess collection over here in the hair follicle or the sweat gland. So of course, uh, by draining that area, plus providing them with antibiotics is the treatment of choice for these patients. Okay, what is carbuncle? When there are multiple uh, small areas of pus formation and they are collectively, or you can say abscess in any area which is separated by partitions. Okay, uh, we call it as carbuncle. So see, a carbuncle is a multilocular suppurative extension of a furuncle into the subcutaneous tissue. You can see from this example. So see, now this is not just a furuncle, rather it's a carbuncle. Okay, because this one is um, multilocular. There are small areas of pus formation, and it is uh, spread into the subcutaneous tissue. This is called as carbuncle. Okay, you can see over here. This one is like how necrotizing fasciitis look like. You can see over here, right? You can see see the gangrene, the blackish, the necrotized tissue, the dead tissue, right? And that's why widespread uh, what you can say debridement or excision of the tissue is needed. Okay, so necrotizing soft tissue infection, we have discussed this thing. So see, deep infection of the skin and soft tissues that may spread rapidly along facial planes. Diagnosis is purely clinical. Dishwater discharge, gray tissue, pain out of proportion to examination. Okay, this one is very important. uh, when on examination you found like the area is not that much damaged, but the patient is feeling more pain compared to like what area is damaged, it is one of a very important clinical point. Bulla and dark golden discoloration is there. Treatment is true it's a true surgical emergency antibiotic with debridement, right? So this is how it looks like. uh, okay, so this one is like the common pathogens and the toxic shock syndrome, you can say. So again, like there is a discussion about tetanus, and like in more detail, of course we are not discussing tetanus over here, rather I'm just giving you an overview of how surgical infections look like. So see, the same thing are written over here which we have already discussed: tetanospasmin and tetanolysin. And like this is how tetanus produce the signs and symptoms, right? So I give you an overview of this thing because when you will study what you can say the infectious diseases, you are going to study tetanus in detail over there and how it is managed. Okay, and the table I was talking about, like how they vaccinate them when they decide either the vaccination is needed or not. Okay. Okay, so uh, treatment of tetanus, debridement, penicillin G, tetanus immunoglobulins, respiratory supports, muscle relaxants can be needed. Okay. Then there is post-operative infections. Uh, why I'm not talking about this thing, because in my previous lecture I have already talked about these 5 W's. Okay, wind, water, walking, wonder drugs, and wound. Right? We have a good discussion on this thing in previous lectures. If you have missed any of the lecture, uh, you can go back. You can you can uh, read them. You can listen to the lecture. Okay, I told you about this mnemonic. I told you about this. What is wind, water, walking, wonder drugs, and wound. So in other hospital acquired infection, guys, there is UTIs, there is catheter infections, and there is pneumonia. Again, in my previous lecture, I have talked about this thing: what is post-operative pneumonia, what is atelectasis, what is catheter infections or catheter site infections, and what is all these things, right? Pneumonia you are going to study a lot of times during your internal medicine. So of course, like surgical patients, they are at risk of developing pneumonia, especially when they require mechanical ventilation. Uh, uh, so we call it as uh, like anyone who is getting pneumonia 48 to 72 hours after endotracheal intubation, we call it as VAP, or you can say ventilator acquired pneumonia, right? So nowadays, of course, the incidence is decreasing because of better understanding of the pathophysiology behind that, and also uh, availability of antibiotics which are used to treat multiple drug resistant pathogens. So of course, like nowadays the incidence is decreasing, but still it is there. So now, uh, of course, anyone who is developing pneumonia, especially as a result of that, there are other, what you can say, hospital acquired pneumonias, for example, like sorry, there are like in hospitalized patient, of course, the organisms are different, right? Like MRSA can be there, methicillin resistant Staphylococcus aureus, or Haemophilus influenza, or anything like this. Okay, so how to treat that pneumonia? Of course, like when you will study pneumonia, you would know what kind of antibiotics they use, what are the risk factors, okay, and all these things. So one of the thing is this one. And then if I'll talk about indwelling catheter infection, of course, like the patients who are in hospital, they put catheters, they put CVP line, they put peripheral catheters, or any other type of catheters, whatever like they are using, even like catheter when they put catheterize the bladder, so it can result into UTI. So of course, a lot of things are there. Uh, what was the insertion technique? Either sterilization was used or not? What is the condition of the patient? What is the nutritional status? What is the age? All these things, they play a role in either the patient are going to develop this or not. But of course, like when good aseptic measures are used, the chances are less. But of course, it's still there. So infection risk is highest for femoral vein catheter and lowest for catheter placed via subclavian route. And peripheral vein catheters, and especially the tunneled central venous catheters like Hickman catheter, they having decreased chances of getting infected. But in simple words, all the intravenous or intravascular catheters or devices which are used, they can be contaminated, they can develop infections. So anyhow, like just a general idea, if I will give you, any surgical patient who will develop infections as a result of these things, uh, we take swabs from that areas, we send it to the labs, and uh, they check it, they found what is the organism, and we start giving antibiotics according to that results, right? So this thing, and one thing which is urinary tract infection, again catheter associated urinary tract infections are also can be there. Of course, like the most common organism which can cause UTI is E. coli, but of course, like whenever it is catheter related, so there could be others as well. For example, there could be enterococcus, or there could be fungal infections, and there could be many others. So, but again, uh, urine sample can be taken, can be sent to the labs, and can be checked like what kind of infection, or what is the organism which is causing infection, and then the particular or the specific antibiotics can be provided to the patient. So nowadays, the urine dipsticks are available, which can check the leukocytes or the nitrates. The nitrate test can be done. The nitrate test, it basically check either if there are nitrate converting bacteria are there or not. For example, enterobacteria, they convert nitrate to nitrite. Okay, so things like this. So catheter related infections can be there. Of course, when we take the patient to, we admit the person for surgery, they put them with catheters, intravenous catheters, they put them with urinary catheters. So, of course, like they also end up in surgical infections. Okay, so after that, uh, there are some points about how to you choose antibiotics, or which antibiotics to use. So, use only when indicated. Start with broad spectrum antibiotic designed to cover likely pathogen. Take cultures when possible, and de-escalate spectrum once pathogen is known. Have a plan for duration. So again, this thing is very common things. Uh, we must use the specific antibiotics when the results are known, when the lab tell you like this is the specific bacteria which is infecting this person. So of course provide only that specific bacteria antibiotic, and provide for the proper duration. Okay, so whenever we give antibiotics empirically, we always should know according to our knowledge what kind of empirical antibiotic is best, what is the best route, either to give it orally, intravenously, locally. Okay. By the way, this discussion I'm not going to doing a pinpoint discussion, because there are certain hospital protocols as well. Like different care centers, different hospitals, different countries, they have their own protocols. Uh, in China it's different, in America it's different, in UK it's different, in African countries it's different, in South Asian countries it's different. It completely depends on the availability, uh, and many other factors are there. There are financial factors are there as well. So that's why we are not discussing that thing in too much detail. Okay, then choice of antibiotic for prophylaxis. See empirical cover against expected pathogen with local hospital guidelines. See again the same thing, local hospital guidelines. Single shot intravenous administration and induction of anesthesia. Repeat only in prosthetic surgery, long operations, or if there is excessive blood loss. Continuous therapy if there is unexpected contamination. Of course, penicillin penicillin should be used if Clostridium gas gangrene infection is a possibility. Patients with heart valve disease or prosthesis should be protected from bacteremia caused by dental work, urethral instrumentation, or visual surgery. So, these things. Uh, so, uh, of course, like nowadays, uh, the hospitals and the researchers, they are working in this direction. Like they are making the surgeries minimally invasive. They are making the patient stays in the hospital as short as possible. Um, there is better antiseptic are available. There are better antibiotics are available. There are better sterilization processes are available. There is more awareness among healthcare workers and the general population. Okay, now the hospitals are much cleaner, and clean your hands campaign is everywhere. Okay, uh, the doctors who have, what you can say, any infections, they don't do any surgery. There are better scrubbing techniques, there are better operating theaters, there are better pre-operative management, like antiseptic baths are now very much, and they shave the person. All these things, they have decreased, what you can say, uh, the surgical infections to a very 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 low rate. One of the thing, like in surgical uh, experiments which they will ask you to do, or which they will take you to the hospitals, in that one they will tell you how to scrub your hands and how to prepare, like, or at least they will show you how the surgeons, or you can YouTube that. You see many scrubbing videos, on YouTube as well. So you can use them. Uh, what you can say, uh, easily. Okay. Last but not least, of course, there are occupational bloodborne infections as well: hepatitis B, hepatitis C, and HIV. So risk from needle stick, uh, like some surgeon, doctor, healthcare worker who get a needle prick. So see the highest chances of getting infection of the needle prick. See 30%. The highest chances is hepatitis B. The lowest chances is of HIV. Right. So uh, what you can say, this is also very important information. Okay, so you can see like what is the risk factor. So see, if you get a needle prick from a person who have three conditions like hepatitis B virus, C virus, and HIV, most probably you will get hepatitis B, but very less chances you will get HIV. Okay, and chemoprophylaxis is available for HPV and HIV, but not for hepatitis C, and vaccination is only available for hepatitis B. The same thing I was talking about, the preoperative preparation. See, now the hospital stairs are shorter. Medical staff should always wash their hands, clean your hand campaigns. Staff with open infected skin lesions should not enter the operating theaters, and preoperative shaving if needed immediately before surgery. Aqueous antiseptic should scrub the nails. Repeated extensive scrubbing releases more organism than it removes. Oh yes, this is very important. Scrubbing once is important, but if you will over scrub, maybe it will increase the organisms. Okay, one application of an alcoholic antiseptic is adequate. It results in 95% reduction in bacterial count. And theatre techniques and discipline should be followed. Regular surveillance is needed to ensure the quality of theatre ventilation, instrument sterilization, and aseptic techniques. So, antibiotics used in treatment and prophylaxis of surgical infections, penicillins, flucloxacillin, ampicillin, and amoxicillins, and a long list is there, right? Um, Azlocillins, phylosporins, aminoglycosides, vancomycin, imidazoles, carbapenems, quinolones. This is again a type of surgery, and what are the most common organisms which are encountered, and what are the prophylactic regimes which are suggested. You can see in vascular you can encounter MRSA, Staphylococcus aureus, methicillin resistant. In small bowel you can encounter anaerobes, mainly bacterides. In appendix or in biliary area, in esophagogastric area, in orthopedic surgeries. And what are the prophylactic regimes which are suggested? But again, I'm not. That's what I told you, that hospital protocols follow that. Involvement of a surgeon with HIV patient. So whenever a surgeon is dealing with HIV patient, it's better to whenever there is a risk of splashing, for example, whenever they are doing orthopedic surgery, so they should use full face mask, uh, protective spectacles, use of fully waterproof disposable gowns, and drapes should be used. They should wear boots. Okay, because for example, whenever if there is any mishap, like they drop a scalp or anything like the scalpel or any pointed object, they should not damage their feet. They must use double gloving. Okay, uh, only expert personnel should be in the theater. Avoid unnecessary movement in theater, and uh, there should be, like, all the sharps, things, objects which are used in surgery should be transported in kidney dish, and a slow meticulous operative technique is needed. After contamination, and needle stick injuries are commonest on the non-dominant index finger. Okay, and whenever, like, you are giving any pointed object to the surgeon or to the helper, of course, like, it should not be the pointed, uh, what you can say, side should be towards you. Okay, not like towards the person. So hollow needle injury carries the greatest risk of HIV transmission. The injured part should be washed under running water, and the incident should be reported. And then again, according to the hospital or the area guidelines, they must be started with, uh, like, the retroviral therapy. Okay, highly active antiretroviral therapy should be given. And occupational advice is required after high risk exposure, together with the need for HIV testing and the option for continuation in operative specialty. So anyhow, like, these things, I don't think so like you guys will understand completely. I think, like, it's just an introduction about all these things. There is a lot of discussion. When you will study HIV, you will understand these things better. And a lot of what you can say, uh, area to area or hospital to hospital or country to country, things are different in these regards. So thank you so much, guys, for listening to this lecture. I hope you understand, and I will see you in the next lecture.